Now it is my great pleasure to introduce Zamawa Arenas, founder and CEO of Qualitative, a market research firm specializing in supporting public health and mission-driven organizations. And so fortunately for us, our main researcher collaborator for these last 3 years. Zamawa is going to walk us through the major qualitative findings of this year's research. Over to you, Zamawa.
Thank you, Anna, and good afternoon, everyone. It's a pleasure to be with you to present our major qualitative findings. And please note, with the quantitative findings, there will be additional qualitative findings that we will release in the future. Specifically for the qualitative phase of the research, we wanted to humanize the data and get a better understanding of people's lived experiences and what matters to them. We began by engaging with approximately 600 adults from all over the country who we recruited based on census matching. And we oversampled Black and Latinx participants, people with serious illness, people with disabilities, and caregivers. The purpose was to gather insights into strategies, concepts, and communications that can help improve serious illness care with a focus on marginalized communities that you've heard. We designed the study in 2 parts, and we used a mix of open-ended questions, narratives, and scenarios for testing, and again, as a way to understand what's important to people. In June and July, we engaged with research participants over 2 weeks for exploration of experiences that were focused on communications, relationship building, and decision-making. We also tested interactions and concepts in the forms of 12 conversation statements, 4 quality care definitions, and 5 care models. Informed by part 1 findings, in August, we put together part 2 with all new participants. And over a week, we explored survey questions we needed further insight on and tested narratives and scenarios to help zero in on what traditional ACP and shared decision-making calls to action people believe will have the greatest impact on their health and well-being. And I should say that people in the research were very committed. They were very open in sharing their stories with us. It was quite a privilege to be able to be part of their lives during that time. So part 1, we started by asking people to tell us what comes to mind when they think of healthcare. People reflected on their interactions with clinicians, office staff, health insurance representatives. Many thought about their health, their experiences dating back 5, 10, 15, even 20 years, not just the 18 months or so of COVID. And they told us about the good and the bad. They highlighted experiences that have impacted them and shaped their perceptions and expectations of healthcare. 5 themes stood out. And for most people, there's a strong perception that the health system is focused on making profits and money. The dominant belief is that individuals are treated as a number, and the perception of healthcare as an industry, a conveyor belt approach to treating patients, with doctors being obligated to meet quotas, was a recurring theme. There was also a strong belief that the system is to blame for individuals' negative experiences, such as being rushed through appointments, waiting months to get referrals, having care limited by the type of insurance, the high cost of care, et cetera, et cetera. In people's minds, clinicians, office staff, and health insurance representatives are the face of the system. And while COVID exacerbated the negative, many tolerated and accepted the challenges as something to be expected and appreciated how their doctors, clinicians went above and beyond to make them feel safe and being able to be accessible through virtual appointments. There was not a real sense that the COVID had lowered people's trust in the healthcare system. In fact, many were grateful for how they were treated. Empathy was consistently referred to as an essential quality that defines the good and best clinicians and office staff. People also want clinicians to focus on their well-being, not just on the illness, but rather understand other health challenges they face that can aggravate their illness. For example, a doctor treating a heart condition, but not being aware or making an attempt to understand the individual's mental health challenges. We also heard many stories, personal stories of experiences that influence people's trust in the healthcare system and in clinicians. So I'm going to focus on trust next. Trust in the health system constantly goes through a process of trust building and trust eroding experiences. And this happens throughout the entire process of healthcare engagement. People find themselves navigating a dynamic process that involves both the trust building and trust eroding experiences from their interactions, again, with clinicians, office staff, health insurance representatives. This is not a static or unchangeable process. And through it all, what people simply want is to be treated as a human being, not a number. Across all participants, including Black, Latinx, people with serious illness, disabilities, and caregivers, a noticeable contingent told stories of positive care experiences that stemmed from clinicians and office staff showing empathy, kindness, competency, efficiency, and making the effort to listen and make them feel as a human being. Good experiences weren't just limited to long-term clinical relationships. Participants shared many micro trust building moments of respect and kindness that can happen all throughout each healthcare setting. When people have trust building experiences, they feel heard and understood. They feel seen as a whole person, not just the illness. They trust that clinicians have their back and get them. And they feel they are in partnership with their doctors and their health team and also involved in decision making. People also shared myriad of trust eroding experiences. They indicated that some of these were really a mix of discrimination and racism, lack of empathy, poor communication and listening skills, and limited access to care. When trust eroding experiences occur, people feel judged, talked down to, not believed. They get frustrated and anxious dealing with the healthcare system. They feel disregard for their mental health and overall well-being, and they struggle getting the care and supports they need. There is a strong perception that negative healthcare experiences are widespread, while positive healthcare experiences seem to be more isolated and the luck of the draw, as one of the participants said. With these insights, we moved into testing, first using 12 conversation statements that reflected what clinicians might say in a typical appointment. We wrote the statements based on learnings from our first phase of listening to the community, as Anna highlighted. And here you can see the first sentence of each of the conversation statements. The full statements and the full text are included in your packet. The statements touch on concepts of competence, expertise, collaboration, decision-making, speaking up, cost, and convenience. Participants read through each of the statements and used a highlighting tool to share which words and phrases resonated and which did not for each one of them. We then engaged them in discussion about their feedback, asked them to select the statement that resonated the most and least, and to tell us why. I will next review the statements that are highlighted in bold. We'll figure this out together. I know that healthcare treatments can be expensive. I'm keeping up with the latest research, treatments, and ideas, and your time matters to me. Here you can see an output of the statement and words that resonated most across all participants. People overwhelmingly selected a collaborative approach to care, summarized in this sentiment. We'll figure this out together. We were also able to review responses by Black, Latinx, people with serious illness, disabilities, and caregivers. And in this case, there were no meaningful differences. Across all groups, people worry that disclosing concerns about medical costs can alter or affect the care and treatment options. However, people appreciate and are inclined to trust clinicians who recognize that healthcare treatments can be expensive. They want to be reassured that if they share concerns about costs, their doctor will not withhold treatments and choices that will help them. Expertise and competence play out in nuanced ways. People expect and want expert doctors. However, statements of expertise were often perceived as arrogant, reinforcing the power imbalance and suggesting that the clinician would not be collaborative. On the other hand, statements like keeping up with the latest research convey expertise and a willingness to learn, reinforcing an openness and collaborative approach, which is what people really value. Statements about respecting a patient's time were not necessarily believable. Most people share the common experience of waiting for doctors who are running late or feeling rushed through appointments. So this statement did not resonate. During exploration, we asked participants to tell us what quality care looks like to them. And we used their responses to write 4 quality care definitions and tested each using the highlighting exercise. And people again selected the statement that resonated the most and least and told us why. Overall, people had really strong views about what good quality care looks like. Essentially, what people deeply value is mutual respect, collaboration, and non-judgmental, empathetic care from their clinicians. This sentiment is captured in the top two statements. Good quality care is collaborative with me, resonated most overall and with caregivers, and good quality care is kind, empathetic, patient, non-judgmental, resonated most with Black, Latinx, people with serious illness and disabilities. People felt neutral about the definition of good quality care based on competence and expertise because this should be a given. Good quality care as timely, convenient, and coordinated did not resonate, and this was an issue of believability. So what does this all mean? People want partnership, and while timeliness and expertise are important, those are just table stakes. Being treated like a whole person is the real differentiator. It bothers people to try and sell what they perceive to be things that should be basic expectations. Basic courtesies and human decency should not be positioned as a nice to have. This perspective helps explain why people downplayed expertise and competency, which again, they just expect as a given. We also heard from a good number of people who shared their stories of empowerment, how they grew tired of unsatisfactory experiences with their doctor or other health professionals and made a change. Some had done this multiple times over. They were committed to finding a doctor or a practice that met their expectations. For some, doing so meant some trade-offs, and they were willing to have those trade-offs. And those included time, like scheduling appointments with specialists several months out or waiting for doctors running late, all in return for high quality care, which in their minds is defined as that doctor who treats them as a human being, who shows empathy, truly listens, advocates for them, involves them in decision-making, and ultimately makes them feel better. That is really what matters most. So as we completed this first phase, this first part of the research, we moved into part two. And for this, here you can see that we had 4 calls to action that we tested. And for this second part, we recruited new participants, about 280 people engaged in this part of the research. And we asked them again to review texts to give us their feedback on words that resonated and words that did not resonate, so that we could, again, zero in on what traditional ACP and shared decision-making calls to action people will believe have the greatest impact in their health and well-being. We split people into 3 communities, and each community saw these call to actions in a different context. The calls to action were about speaking up, pick a proxy, do end-of-life planning, and pick the right doctor. Community 1 saw them all as a public health campaign, and we asked people to imagine seeing these as part of PSAs or posters. Community 2 read them as a part of a simple letter from their doctor's office, and Community 3 read them as part of an expanded letter from their doctor's office, using much of the language about collaboration and empathy that tested really well in July. And let me note that we did not include the call to action, you can look for the right doctor, in the doctor's office letters. This was only viewed by those who participated in the public health test. Like in the previous test, people used the highlighting tool, and in this case, rated each call to action on believability, difficulty, and greatest impact. That you can speak up and have a say in your care call to action was believable and deemed to have the greatest positive impact overall, and especially when presented as clinician communication. It was also perceived as most difficult to do when delivered by healthcare providers and slightly less difficult to do when presented as marketing campaign language. While not difficult to do, you can make a plan for your healthcare. The pick a proxy call to action was deemed to have the least impact and was often associated with getting end-of-life affairs in order. And again, I want to note here that many participants did not seem to think that there was a meaningful difference between these 2 calls to action. Here you can see the breakdown for the public health campaign treatment. You can speak up and have a say in your care, rated as having the greatest impact for Black and Latinx respondents, as well as people with serious illness. In this case, for people with disabilities and caregivers, the additional option of you can pick the right doctor was seen as the most impactful, although it was perceived as more difficult and less believable than you can speak up. This table shows the breakdown in the doctor's office treatment. All groups selected, you can speak up as the most impactful action in their health and well-being. People nearly unanimously recognize that speaking up about what matters, what works for them, and picking the right doctor is the most impactful and valuable thing that they can do among traditional ACP and shared decision-making calls to actions. But people also know it can be a hard thing to do because the clinician's response is not always in their control, and they can't always switch doctors. And in some ways, their lived reality of negative health care experiences can hold them back. That being said, across our entire qualitative research phase, there was a strong sense that people of all racial and ethnic groups and income levels want to and are willing to speak up, especially Black and Latinx. And the desire and willingness to speak up seems to be increasing as people express feeling more empowered and inclined to question power structures in our country. At the end of the online communities, we asked people to reflect on their participation in the research and share some advice for the coalition. Participants shared that they were inspired to do something new and different given their experience in the online communities. Some gained the confidence and were ready to speak up. Others were inspired by their peers and wanted to search for a new doctor. Others decided that what they had to do was put their end-of-life affairs in order. And for others, it was about time to pick a proxy. They also appreciated that the coalition was asking these questions and that their opinions and experiences might lead to more positive healthcare change, even though it might not impact them directly. And they want the coalition to keep working to prioritize collaborative care and giving patients a voice. I'll end with some advice for the coalition from a participant with a serious illness. Her words capture the sentiments of many of the hundreds of people we engaged. Please keep pushing to make care better for people, to raise your standards and to improve anything you can. Thank you very much, and I will turn it over to Anna.
Thank you so much, Zamala, and the entire Floetic team. Also a huge thanks to Tony Bach from the University of Washington, who leads the Message Lab project, which supported this work both financially and intellectually. Again, full list of collaborators is in the session resources PDF document along with these findings.